chair. I think most of you know me by now. We do have some new council members on today, so I wonder if each one of you could unmute yourselves and tell us a little about yourself, your name, what you do, and your reason for joining the council, or what you kind of hope to bring to the council. So Lauren, I see you first on my list, so how about you start?
Sure. Good afternoon, everyone. It's good to see your faces. So I am currently an assistant professor of psychiatry and behavioral sciences at Meharry Medical College, and I'm the director of trauma and HIV studies in the Center for the Study of Social Determinants of Health. And previously was at Nashville Cares for about 4.5 years, I believe, and still work very intensively with Nashville Cares as one of my primary research partners, as well as Meharry Wellness at this point in St. Jude Children's Research Hospital. And what I hope to bring to the council, well, I don't really have a specific agenda other than just really, I guess, trying to more strongly connect what I know I've been doing in kind of side working groups to integrate it more into this group so that we have more fluid kind of communication. But that's just one thing. I'm also excited and open to contributing in other ways beyond my own specific work. So I'm excited to connect more with all of you and to see how I can contribute as things arise.
Thanks, Lauren. We're really glad to have you on board. Tai, how about you?
Good afternoon. My name is Tai Link. I'm director of the peer program at Nashville Cares. I've been there 9 years. And what I hope to bring is just the voice of the community of individuals living with HIV. And I'm excited to be on the group.
Thanks, Tai. Glad to have you. All right, Shamar, you're up.
Well, hello, I'm Shamar Gunn. I'm the prevention director here at StreetWorks. I've been with StreetWorks for about 4 years now. Previously, I was with Nashville Cares as well. Right now, I just oversee everything HIV prevention. I'm also over a prevention intervention program called Many Man, Many Voices, which is for Black gay men, the ages of 18 to 35. So I guess I'm just here to bring like a young perspective from the LGBT side as well to the council. So happy to be here, you guys.
Awesome, thanks. Welcome, Shamar. Glad to have you as well. All right, so I don't think we've quite reached quorum to approve the minutes from last meeting, so we'll just move ahead to the next item on the agenda. Morgan, do you want to give a quick work group update?
Sure, and I'll tag Brady too if there's anything you want to add to what I'm going to say, Brady. But I only have updates for the U equals U task force, but things are going really well. Last Thursday on World AIDS Day, we had a soft launch of the campaign, and so that happened on social media, on MPHD's Facebook and Instagram pages. We shared some images from the photo shoots with the ambassadors and had a really great message about the meaning of U equals U. And yeah, it was really great to see. Okay, well, it was really great to see like the work that we've been doing actually like come to fruition. And it's just the beginning. And Brady and I have met with Matt Peters here at the Public Health Department to talk a lot about marketing with the campaign, and he has really good ideas, and it's just really exciting. So, Brady, do you want to add anything?
I'll just add that we've connected with the new US U equals U group, and they will be conducting an orientation and training for our new ambassadors on this coming Monday. So I'm really looking forward to that. And we've also gone through, Morgan did an amazing interview with all 4 of the ambassadors, and those of us on the task force are currently in the process of going back and reviewing those videos so that we can kind of turn those notes over to Matt in marketing. And we can kind of help create or help these ambassadors create messaging within their own voice, and how to style them and all that for their future postings. So yeah, there's just been a lot of work been going on, and it's just really exciting, like Morgan said, to see it coming to fruition. And I'm really, as a person also living with HIV, I'm just really excited about these 4 individuals getting to share their stories, and hopefully, hitting all of those pillars of the cascade of care, and also at the same time reducing community stigma around HIV and helping to normalize the conversation about HIV. So lots of good stuff. Thanks, Morgan.
Thanks, Brady. Dr. Brown, do you have any updates from trauma-informed care or equity? I did reach out to Jamie, but I don't know if she had any new ones for the past couple months. So
I think I do, but I was trying to remember the last time I gave you all an update. Do you know, since I'm not looking at the minutes. I know I wasn't on the last meeting. I'm trying to think about timelines. I'm not sure if I think I at least told this group that we were planning to do a retreat. Have we talked about the retreat findings here?
I don't actually think that we ever did that.
Okay. Well, the number one finding, I will say that we had about a day and a half retreat, pretty intensive, with a dinner one day, where we just kind of went over all the data from the one-on-one interviews with 35 personnel throughout 5 different HIV care institutions in Metro Nashville. And we asked them about 50% of the questions were about just really kind of the status quo of how we screen for and respond to psychological trauma as well as mental health, and substance use in our HIV clinics and organizations. And about the other 50% centered on cultural responsiveness. So asking questions about just kind of generally if people feel safe in their workspaces psychologically, if they find them to be stable and nurturing environments. And then really if their perception is that it's safe for their patients and clients. And so that's the gist of it. And we put together some themes. I don't think that I've shared them all with this group, but we basically then presented those themes back to a group of leaders. And after in a luncheon after the HIV symposium, whenever that was, October, I think, September, the end of September.
September.
Okay, yeah. And basically through that group, we discussed kind of the 4 overarching, and I don't actually have them in front of me, I apologize, but the 4 overarching recommendations, if you will, that came out of the retreat. One was that we create a trauma-informed care, kind of resilient care coordinating center that could help all of Metro Nashville really work together fluidly rather. And the push was really, or the suggestion was really to do that at Meharry, but also kind of talking through, who could really participate in that, how it could really be something that is Metro wide. With inherently, it has to sit in a institution. And so how could it sit in an institution, but also incorporate members from all over? And so that was the number one thing that came out. And actually the group of leaders voted that that was most important, because all the other things that we came up with, which were things like, one of the other 4 was to create a dashboard so that we could in real time know what services are available between our institutions, so that, people would know what's out there and kind of what the census or capacity is to provide those services. So kind of like a referral dashboard. And generally the group of leaders felt like creating this steering committee, or not steering committee, but a coordinating center is the primary important thing to do, because the rest would come out of that. The coordinating center could basically drive the remainder of those things. One other recommendation that came out was generally about increasing attention to personnel quality of life. So relative to personnel having stronger, more robust access to mental health themselves, as they have vicarious trauma as an occupational hazard of their work. And then also, I believe the last one was related to cultural responsiveness. And these were kind of bigger categories, but just really how to kick off cultural responsiveness, cultural humility, kind of adoption across all of our Metro Nashville institutions. So that's where we landed. Claire, anything else to add, or do you think I'm missing anything?
No, I just wanted to say that Lauren and Jamie did a really wonderful job organizing the retreat, and it was a really productive couple of days, and just a really great experience getting to sort of be in the same room as other people and working through different issues together. And so it was really exciting. And I think the idea of a citywide coordinating center is really exciting and just very much in the spirit of EHE.
Thank you. Yeah, I appreciate that. And there's several people on this call who participated, and I just cannot say enough how amazing and inspirational it was to me. And I know, if not everyone, most everyone in that retreat, to see people really show up for that. I know that we all have a lot to do. So it says a lot of, that you all showed up and spent your time doing that. So the next thing is really just to build on that momentum. I will say that we've received a seed grant, several $millions, to specifically look at trauma resilience with Tennessee Department of Health personnel. And we're hoping that this can really be the seed grant that can launch this coordinating center. Of course, the monies are specifically for personnel TDH, but we're hoping that what we do with TDH, we can really kind of use to leverage some other resources to push together something with this coordinating center. So that is in the works. And any of you who participated in the past in the symposium or the retreat, we do have some of those findings that we're writing up, and we will be in touch to incorporate you as to acknowledge you, and also talk about authorship and anything that's scientific. Any questions about what I went over? Any feedback? Thank you.
All right, so we will move along then. And we have a few different items up for discussion. So first, we're going to talk about sort of continuing the conversation that was started during the last meeting about HIV criminalization in Tennessee. And Brady brought up the recent Williams Institute report on the enforcement of HIV criminalization in Tennessee. So we're going to play an accompanying video interview between Dr. Robin Lennon Deering from the University of Memphis and Mariah Wilberg from the Prevention Access Campaign, and discuss the role that EHE Nashville can or should play in addressing that issue. So Morgan, are you able to share that video for us?
I'm going to do my best to pull that up, but also, so Dash, I realized I did not send you the agenda, so I didn't really let you know where in the meeting you would be coming up. And I think, do you have, right now I have you as after a couple more discussions, but do you have any time constraints? Would you need to? Okay, cool. Also, it's Dr. Shah Kai Kai's birthday. Happy birthday, Dr. Shah Kai Kai.
Thank you, Morgan.
Happy birthday.
Happy birthday.
Dr. Shaka
Thank-
Kai, it's also my husband's birthday as well as Jamie's that we
All
mentioned
right.
earlier. So very
Okay.
special.
Okay, let me try to pull this up.
I didn't realize I was muted earlier. No, I don't have any time constraints.
Can you see the screen of the YouTube
Yes.
videos?
Yes.
Okay. Did you hear it earlier when it was playing?
No.
Try again. No.
Can you hear that? No?
Next to the microphone at the bottom of the WebEx screen, is there possibly a different output or for a different sound? And maybe it links to the video.
Hmm. I don't know. I clicked it. I didn't see an option though. This might not. I might have to just send this to you all and have you watch it.
So did you click on the little arrow next to your mute unmute button and see, is that what you were trying to do before?
No, I went to the more, like the options and controls.
You might be able to click on audio settings there and yeah, I don't use WebEx much, so I could tell you how to do it on Zoom, but I don't know for WebEx.
Yeah. Let's move on and I'll like play around with it.
Okay. Sounds good. We'll just move on to the next item for discussion and come back to this one. So the next topic of discussion is another one that we kind of started discussing during the last meeting, and it seemed like something that was worth spending a little bit more time talking about. And that's the implication of the 340B changes. So during our last meeting, Rich began a discussion about those changes and the implications on PrEP uptake in Davidson County. Just want to open the floor for further discussion about this, especially if anyone has any ideas about how this council specifically can respond or take some form of action regarding those changes. And oh, hey, Rich, I was hoping you would be able to, I didn't know if you could turn your camera on or not, but Rich, do you want to give everyone an update on the local response plan and what you all are up to?
We've had some media attention to the changes at the clinic. And these are the changes that I outlined last month that would be occurring. Primarily, we had been one of the largest STI testing centers for the general public in the state, with the aspiration of converting as many of those people to either PrEP or ART if we noted that that was the appropriate route for them. But because of the changes with 340B, it's no longer sustainable for us to provide, which is essentially a government function, to provide general testing to the public at no charge. So we're now relying on community partners to share that responsibility with us. And we've limited our STI testing only to that is driven by the PrEP protocol itself. So if you are on PrEP, the protocol, as you know, requires regular STI testing. And since HIV prevention is our mission, our testing has now been limited to that scope, which is a shame because our friends over at Metro Health did acknowledge we probably got more people to participate in regular testing and treatment than would have otherwise happened, largely because of the significant resources that we put into public outreach in the form of Facebook advertising, radio, television, billboards, and even advertising on hookup sites and porn sites where adults are sexually active. So it shows that this kind of investment will, when written properly, messaged properly, or scripted properly, will encourage more people to come in for testing than your usual government outreach programs.
So, Rich, is there any difference in, if somebody comes in, and does it depend whether they're insured or not, this new strategy you have for STI testing?
Okay, so if they are not interested in getting on PrEP or ART, or not currently on PrEP or ART, we only have a very few limited appointments for those patients. So there used to be a walk-in, like just anybody could walk in at any time, and we staffed up appropriately for that. And that was an attempt to reduce the barriers to care, right? So now they need to make an appointment if they are not interested in PrEP or ART for general STI testing. If they are uninsured, then we are matching Metro's price. I think it's like $25 for testing and treatment. As you know, that this is actually not a market price. It's way below our cost to provide this service. But that's kind of where we are at this point. If they are insured, then there are financial aid programs available to make up any difference in the costs that we're billing to insurance versus what their out-of-pocket costs may be. And that is need-based. It's based on household income, using that same kind of gradiated chart that we've all seen for poverty level and relative to the household. That's my dog in the most exciting part of the day. So yeah, I think I finished that point.
So, is anybody else on the call? I don't know the extent to which the other organizations on this call have been utilizing 340B, but are other people having issues, or other people having to change the way that they provide services because of this?
This is Ty. I'm not sure. That's not my area, but I do know that we do provide free testing both at the clinic, Nashville Cares Clinic, and in our mobile unit, which we just started, and both provide PrEP and also HIV testing. I can, get more information for you, and I don't think Amna's on the call today, but I know we still provide the free HIV testing at different locations.
Yes, there are still many places I believe that patients can go. I think that the change is the amount of capacity reduction as that's occurred. At our peak, which was in September, we were adding 600 to 650 new patients a month. These are brand new patients that are registering for services and creating a patient record in the EMR. And that's a phenomenal number of new people interested in their sexual health on a monthly basis. So 600 to 650 on, each month. About half of those were interested only in STI testing and treatment. So that was a very important function that we were providing that was frankly off mission. But the reason why we were doing it was because they are sexually active adults. This was an opportunity for our navigators and clinical team to educate them on PrEP and ART and get them converted to the best that we were able. Okay, so now that we are unable to see that many new patients, we will find that the other partner organizations community will be picking up the slack, but will not be able to. So for example, we were informed by My House that they are already at capacity based on just taking on the patients that we have gone over there, and they're asking us now to call in advance before we send them because they can't take any more. And Metro Health went on record in the paper saying that right now they don't have a capacity crunch, but based on the numbers of new patients who are making appointments for the future, they see that they're going to also be overwhelmed. So the good news is we've got a lot of people in the community who have become interested in their sexual health. The problem now is that we can no longer afford to do that for free at the same levels we were doing. And I doubt that there's any combination of partners in the community that will be able to pick up that same slack without additional levels of funding.
So, Rich, what is the strategy right now? I know that you're doing some political advocacy, trying to get media attention on this, but are there things that this council can do either collectively or some of the individual leaders on this call to sort of advocate for, I guess, different opportunities for funding to pick up with this increased demand for sexual health services?
Yeah, I think the first thing that council members can do is become familiar with the local response document or local response plan. I call it the LRP. There's a link for it. It's a shared document. And it basically lays out the problem at the national level and how it's playing out here at the local level. It also lays out 3 solution paths that are viable. And in fact, the solution paths were suggested by Dashiell. When I asked Claire and Sean Kelly about what their thoughts were we could do, they forwarded the question to Dashiell and he came back with these ideas. So those have been basically adopted into the local response plan. And so what I have done is I've provided progress updates for each of those solution paths. The local response is what we're doing here on solution path 2. So the first path would be, is there anything we can get Gilead to do in terms of their unsupervised, unchecked, unilateral price increases for the medication? In order for the national HIV prevention strategy to work, it depends on 2 cooperative actions. One is that Gilead keeps the price of the medication below the retail price so that there is actually a profit between the wholesale price and the retail price. That's how the 340B frontline clinics and rural hospitals and everybody else basically is able to benefit from the 340B program. But if they keep changing the wholesale price and raising it each month without warning, without discussion, then there's really no way to plan a business around what the cost of goods will be. Okay, just imagine you could be in any business. It doesn't matter where you are, whether in healthcare or you're selling apples, but if your costs keep going up every month and you have no idea what it's going to be the next month, it's hard to stay in the apple business for very long. Okay, the other cooperating factor that's needed is that insurance companies need to cover the brand name medication. In this case, it would be Descovy. If they insist on covering only the generics, again, that leaves no money left in the 340B model for the frontline clinics who are doing this HIV prevention work. So we're caught between a rock and a hard place. Our 340B costs are going up on the wholesale side. So the pharmaceuticals are taking money off the table. That's Gilead. And then the health insurance companies are increasingly trying to divert everyone to generic or not cover Descovy to the same degree that they did before. So that's the squeeze, okay? And as a result of that squeeze, we're no longer able to do all of the things that we were doing that made us so successful. And the local response plan lays out in infographics of how Nashville and Davidson County, well, Tennessee first was down in the bottom 5 states of the union last year when it came to HIV prevention. But because of our efforts, largely because of our efforts, Nashville, Davidson County appeared in the top 5 in the union as if we were a state in our own right. So it shows that an investment matters, but without continued investment, we're probably going to sink back down to the bottom 5 in the country as a state.
And Rich, I think you probably have shared the local response plan with the council before, but would you be able to send it to the chat so everyone's got it handy?
I'm doing that right now. Let's see.
Anyone else have thoughts on this or ideas about what we as a council can do to address the issue?
Last month, the last time we met, there was some feedback that perhaps some of the public outreach that we did was not as culturally sensitive as it could be. And I actually took a little umbrage at that because our messaging was informed by the science, and we bear it out in the fact that 35% of our new patient appointments were from members of the African American and Black communities, which is probably more than double the representation in the general population. So I just thought that was kind of a swipe out of nowhere, but I wanted to push back on that. And the local response plan actually has examples of the television commercials that we developed for those communities that really increased the percentage of those patients showing up for appointments. Some of our research, it's not in this document, but I can just tell you while we're here, is that the public outreach and the navigation and follow through for the African American and Black communities is over 4 times the cost of reaching out to gay white men, for example. That's from our own data.
Hey, Rich, this is Brandon from the mayor's office. Thank you for all that information. I have a question on if there are any lawmakers, perhaps, that you've reached out to or can reach out to for support, or then also, is there any thoughts on perhaps going onto the Hill for the upcoming legislative session to discuss matters? I don't know if that's needed, but I'm just curious to know, has any of those type of conversations started?
Well, I'd reached out to you, Brandon, for those ideas. So yes, I am open to introductions. I know plenty of people who know plenty of people, but so far the actual introductions haven't occurred. Some, a possible reason might have been that people are waiting for the midterms to complete. before stepping into politics. But I think now it's time, or now we're getting to the doldrums of, winter holidays. But I think it would be good to start calendaring some ideas so that when January gets here, we hit the ground running. But absolutely, the politics fall into what's known as what I call solution path 3.
Okay, thank you.
Thank you, Brandon.
I'll connect with you offline.
Fantastic.
I have a question. Anyone connected to now Representative-elect Ogles, Andy Ogles? Okay. So I think for now, we're gonna have to get to him early because he's taken over Representative Cooper's place since the redrawn district lines. So you no longer have a friendly Dem in the US House, but it looks like this person is newly elected and needs to be educated. So I think I'm 30 minutes from the Hill. I can just walk over there. What I'd like to do on the Fast Track City side is we are going to be doing a lot more legislative work and utilizing my space in DC to be able to go to new representatives. So this person will be educated by the Federal AIDS Policy Partnership, which is the FAP. Because they're a new rep, they're going to just be educated immediately. And the GAP on global stuff as well. What I plan to do is take all US reps that have a fast track city in their jurisdiction and go to them, talk to them about fast track cities, but talk to them about specifically what's happening in their cities. And before I do that, when I am going to be doing that, I would like to speak with all of you first and talk about what are the key things that this person needs to hear. So I'm reflecting the voices that they should hear back home so that we are not out of step and out of sync, so they hear it on both ends, because I can't expect you guys just to fly up to Washington and drop of a hat. Like, that should be an expectation. Now, would I love for you to do that, of course, but come up, visit me anytime. But I want to make sure that I'm the best appropriate advocate for what you need, and this looks like something that can definitely be reflected and repeated again and again, and they should hear that echo chamber back home as well.
That's awesome. Thank you, Dash. That'd be great.
I apologize that I missed part of what was said. We're trying to work on the audio for the video that Morgan would like to play. But as far as the health department, we have seen an increase in the number of community members who are interested in PrEP. Of course, nowhere at the capacity that Music City PrEP was able to offer. That's one thing we're looking at doing, is increasing our capacity. Also, we're hopeful that as Ryan White from the federal level administration appears to be more interested in prevention, that they move rapidly towards supporting PrEP. I'm not sure how in the near future. We're told pretty soon, but pretty soon can vary. But that's one thing Beverly and I keep our fingers crossed that we'll be able to offer more support through the Ryan White program. But right now we're so limited, and funding wise, we're limited also. But we hope that there can be something done, and we're willing to help as much as we can on the health department end regarding, this Music City PrEP status. We know that the 340B issue is affecting a lot of organizations. And Morgan, please let us know, I'm sorry, when you're ready for the video.
And also, I think we've reached quorum. So, yes. So maybe we can just quickly vote to, hopefully you've all had an opportunity to review the notes from last meeting that were sent out on November 22nd. Does anyone have any amendments to those notes? Can we get a motion to approve?
Make a motion to approve.
Can we get a second? Anyone? Second? Oh, okay. It's Ty, you raise your hand. All right, just raise your hand if you vote to approve. Can I see a few more hands? You can do your real hand or virtual hand. There we go. Okay, great. Thanks, everyone. Approved. All right, Morgan, are you ready to play that video?
So I made Dr. SK the presenter so that Joe can play it.
We're still not hearing it.
HIV criminal laws do not require people. Can you tell me a little bit more about your research and the main takeaways? Yes, the biggest thing that people don't understand is that the HIV criminal laws do not require people to actually transmit HIV. At least that's the way it is here in Tennessee. In fact, they don't even have
Turn it up.
physical contact. For example,
like, "Can you turn
we
it
have
up?"
two laws. One of them is aggravated prostitution. And with this particular felony law, all they have to do is get into an undercover police officer's car or agree to talk to someone who is an undercover police officer, and they are arrested. So number one, it doesn't mean that you've transmitted HIV. And number two, the people that are arrested are usually financially insecure, perhaps homeless, living on the street. They have no money to fight the charges. And if you do have money or social status, people don't end up incarcerated. They end up somehow getting out of it. But people without financial resources, they get a public defender who usually tells them to plead guilty and take the time without telling them about the consequences, such as the sex offender registry and how that's going to follow them for the rest of their lives. Is there anything else that you'd like to share about your research or about HIV criminalization in Tennessee? Well, again, there's no legal requirement for a consenting adult to be put on the sex offender registry. And there's no research that consenting adults with HIV should be on the sex offender registry. So this is an extremely severe discrimination that is affecting people that are living with HIV, and we need to bring it to the attention of our lawmakers, policymakers, and the public so that we can get these laws modernized and updated.
Millions find a low-cost health plan at healthcare.gov so they can enjoy more visits.
Were you all able to hear it okay?
Yep.
Yes, thank you so much.
Thanks, Joe. Is there another video? No, okay.
No, that's all.
Thanks, Dr. Shakagai.
Will we be needing Joe's services again?
I don't think so. Thank you.
Thank you so much.
So does anyone have any thoughts about, again, strategies for this council in terms of modernizing some of these HIV criminalization laws?
Dr. Tai, did you have your hand up?
Oh, I left it up, but I can still speak a little bit on it. We went to the Day on the Hill last year, spoke with Senator Yarbrough, and who was for, getting rid of the bill. However, it didn't happen. Um, and he was saying that we had to dial it down a little bit. And I think, Brady, if I'm wrong, I think it was shaved a lot from the original bill. The bill that we presented was shaved down a lot, but it was still an issue with getting it passed. Um, and so I think it's going to be brought back on the floor in January. But yeah.
Thank you for that, Tai. I think that the only way that we are going to be successful, especially in this state, to actually make any kind of meaningful changes to HIV criminalization laws is we are going to have to invest in people living with HIV and getting them to these offices and getting to talk to the representatives one-on-one and hearing our stories. Yeah, I know that it was, hearing from some of the lobbyists that worked on this, as soon as they mentioned HIV, it just shut down conversations. Conversations weren't able to happen. There were jokes made. It was seen, talked about like a joke. And I think we need to do more to lift up and bring those of us living with lived experience, how these laws have impacted us, whether we have been incarcerated or not been incarcerated, speaking about the power dynamic that just the existence of these laws create and how they endanger the lives of those of us living with HIV just in their existence. Our legislators, they need to hear these stories. So if there's a way that I think that needs to be one of our big focuses is helping to educate those with lived experience, how to tell their stories and helping them get to these offices so those stories can be heard.
I think I saw Lauren's hand. Did you have something to add?
I think that, do you pronounce your name Deshelle?
Yeah, you just call me Dash.
Okay, I think Dash's hand was up first.
I recently sat in on a congressional hearing for HIV decriminalization, or the criminalization of persons with HIV, both domestically and globally. And this conversation is difficult in the context of states in which it's extremely apparent that we have a lot of conservative voices that maybe, like you said, they shut down when it comes to HIV. So the strategies I've heard that have been successful in reaching even those who are open to the idea are couching it in the financial impacts of the state to criminalize individuals with HIV. Even though there is treatment out there, that means that when they have access to treatment, which is normally on their end, the consumer's end, that it means they can't transmit HIV. And to the idea of saying, hey, we're going to shut down everything, wipe off completely HIV criminalization, the messaging forming in, we need to reform these criminalization laws to reflect current science. And I bet we all know there are people up on both in Nashville in the State House and of course on the U.S. Side on the Hill. They are not aware of ART. They're not aware of U equals U at all. And like Brady said, getting people who have lived experience, who can talk about the personal experience, of course. On the U.S. side, on the Hill, there is the repeal. It's called the Repeal Act. That is meant to be federally taking action. Again, reflecting that to Representative Ogle now, saying it's something that your communities in Nashville support, as well as Representative John Rose and Mark Green, who also take a portion of Nashville, since it's been, instead of one district, split up into three. So you have three opportunities to talk to people. And I think taking a look at where it has been successful before in a deeply red state or somewhat red state, North Carolina was able to change their laws in 2018. And they have a law that now encourages or at least recognizes U equals U where after 6 months being on ART and having an undetectable viral load, you are no longer required to disclose your HIV status. So that's one thing. Does it take care of everything? No. But North Carolina was able to get that through, and it brought the idea of this law is meant to be reflective of science, what science says. And before, it was completely the same. Like, you know, these people will go to prison, and there's, again, very broad definitions. And North Carolina AIDS Action advocated for this. They would call it a reform in law. So at least there was some change. And we just need to start pushing that. I'm not a big fan of incrementalism because I know there's a lot that needs to be changed. But to see a success like that was big and raised a lot of eyebrows. So I know those efforts can be successful. So I'm more than happy to connect people here with the North Carolina team that did that. And Durham is a fast track city, Durham, North Carolina. So more than happy to connect where we can on thinking of like state level strategies like that.
Yeah, that's pretty much, I mean, you were much more specific. That's the exact direction that I was going to go in. That specifically about us having a very conservative legislator, and I spent about 10 years working on a really contentious issue, lobbying every year here in Nashville. And how we were successful is exactly what you were saying. We found a way to basically, I think what's critical is having a conservative sponsor. You know, if you have a Democratic sponsor, it's dead. And so a conservative sponsor, and then on top of that, we have to behind the scenes really hobnob with some key conservative folks who aren't necessarily in the legislature that will agree to become part of our movement, that can be the voices of reason that even go in lobbying with us. And so we have different people who play different roles when we go into lobby. You know, we have people with lived experience, we have conservative voices, and absolutely agree, we have to take a financial route. We can't claim a humanitarian route. This has to be something that we pitch as a fiscal, you know, a plan to that where and talk about how we could better use these funds to do X, Y, Z that we know aligns with what people want in our legislator. And I think last thing, absolutely connecting with what North Carolina did is the best way for us to strategize how to move forward with this.
Thanks, both of you. And Beverly, I see your hand up, and I think this is your first meeting, maybe? So is that right? Am I getting that right? Oh, you're muted. You may have attended one.
Yes, I'm sorry. You're correct. It is my first meeting.
Well, if you don't mind, can you, I think most people probably know who you are, but just in case, can you tell everyone who you are and what you're hoping to sort of bring to the advisory council, and then also share whatever you wanted to share about criminalization.
Oh, okay. Well, good afternoon, everyone. It's an honor to be here today with you. I am Beverly Glaze Johnson. I am the director of the Part A program, the Ron White program here at Metro Public Health Department. And I just hope to bring my experience in the HIV arena for too many years to tell. But you probably can guess I'm pretty gray at this point. and and seriously, you know, just find ways to work, you know, systematically to yeah, help improve treatment care and care to people living with HIV, but you know, most of all, you know, reaching some kind of common sense way of thinking about how we can truly end the epidemic. So my comment to the discussion around HIV criminalization is I am familiar with sure you all have heard of Representative Gloria Johnson. She kind of stepped out for a minute, but she was recently reelected. And I know Representative Johnson, actually, of course, our Tennessee state rep, she done a lot of work and, tried to work with several organizations around HIV decriminalization. And there was a bill, I believe it was House Bill 2792, probably about 2 years ago, I think. But as someone indicated, it just kind of stalled in the House Criminal Justice Committee. But I was just wondering, and I hear what Dash and some others have said about working with our federal politicians around this. But I mean, I just wondered if we had thought about there's the Tennessee HIV Modernization Coalition. I'm not sure if anyone here has heard about them, but they do a lot of work around decriminalization. And just wondering if we could possibly consider or would consider inviting Robin Daring to just hear what what they're doing, where they are in the process with re-engaging state legislators around this issue, and just have some ideas of how to move this forward. That was just going to be my recommendation, and actually my thought to kind of start there as well. It's no reason that why engaging our federal legislators, we still may not want may want to consider our state as well.
And Brady shared a link in the chat for everyone. So the group that Beverly referenced. Brady, are you part of that group?
I am, and Beverly, I think that is an absolutely perfect suggestion. Inviting Robin and maybe even Dwayne Morrell. The two of them both have really been at the forefront of pushing this issue, and I think inviting them to at least come and give a brief synopsis to the coalition so that we know exactly what has been, because a lot of what has been mentioned is stuff that the group has talked about and has been working on. So I think that would be the best place to start is inviting them, hearing where that group is, where they stand, some of the successes and relationships that they've already gotten built that we might be able to capitalize on. And then in that way, also identifying areas of opportunity where we could kind of drill down and use our collective resources to help the group move it forward.
Yeah, that sounds like a great idea. And one thing that occurred to me, I think it was Lauren who was talking about the importance of having sort of conservative sponsors. And I think one thing that'll be important to keep in mind is that the federal EHE plan did come about under a Republican administration originally. And I think it's just, even though Nashville EHE isn't a priority jurisdiction yet, maybe one day, but I think it's important to continue to tie the work that we're doing with that federal plan and show that it, remind people that it's not a partisan plan. And I think also tying back or sort of connecting the dots for people who may not understand the connection between criminalization and ending the HIV epidemic and the impact that modernizing HIV criminalization laws can actually have on the numbers across the HIV care continuum. So that's my only thought on the matter. Anyone else have thoughts they want to share?
All of these individuals that have been elected are all extremely tied to Trump and have been supported by Trump, endorsed by Trump, or have endorsed him outright. I think making sure those individuals understand that, again, this is a Trump initiative that started under him. And the way to reach these goals is not through keeping people from getting tested. And couching this again in the financial sense as well, it's much cheaper to get people onto treatment and keep them healthy than it is to put them in a prison and then also take care of their health on top of feeding them and housing them and putting them through that process for the state's end. No one wants that. And just that seems like a better opportunity now, especially now that you have a new representative who was kind of quiet during the campaign, up to the election. Yeah, and whatever I can do on the Hill, this is not tied to only Tennessee. So there will be an opportunity for more federal actions and federal discussions, but for each of the reps, regardless of party affiliation, there will be an ask for them to sign on. And they are all going to hear the U equals U message from me, regardless of who they are when I first meet them. I'll ask them, do you know what PrEP is? And do you know what U equals U is? If you don't know, you're gonna know right now. Flat out. So you can guarantee that from me.
Dash, what is the possibility of this happening at a national federal level?
Be difficult now that the House seat has flipped to a majority Republican, but that doesn't mean that it's going to be impossible because it's only a 1 seat majority. It's not like it's 6, 7, 8, or 10. The red wave was a red puddle, or a breath. So all we really need is a few more pliable, I'm not gonna say pliable because these are people who have brains. They need to be empathetic and understanding. And even if we personally feel like maybe they are never going to be that way, you never know. And that's why I'm going to really, really push on them the understanding of U equals U and the understanding of what PrEP is. And then also the cost to your district to continually put pressure on your police to find these individuals and put them through the process at the state level to pay for them through that is, not financially responsible. And I think they'll hopefully respond to that message. It'll eventually have to click. If I was able to obtain actual financial information, and that's, I think, a partner probably has that, whether it's the Zero project, we're going to partner with them as well on some projects in the future. Maybe there's another institute or someone locally that might be able to put some actual dollars and cents behind it, because we can tie that back to the need for 340B, and getting as many people undetectable as possible means protecting the entire community, which means you don't have to put people at risk for HIV regardless of criminalization or not, A, but B, the cost of that versus the cost of maintaining a criminalization law that doesn't recognize anything. So I don't know if anyone locally might be able to know or be able to have some way to figure that out. I know there's there's ideas nationally, but we're talking about something more local, more like Nashville or Tennessee or your Nashville metro area.
Hey, Claire, I see Amna has joined. Could we maybe ask her about the state of PrEP at my house, given what we were talking about earlier?
Sure. Welcome, Amna. We were discussing 340B and just wondered if you had anything you wanted to add to the conversation about how that might be impacting the provision of services at my house.
Sorry, what about 340B? I'm sorry, I must have missed. I don't know what you're referencing.
Oh, just Gilead's rollback on what's eligible for 340B pricing.
Maybe any impact on PrEP for us at the My House Clinic? Is that the question?
Or STI testing, anything, any services really.
No, actually, we haven't had a serious issue. We're still continuing to support people and find ways to provide them PrEP. I think one of the goals of why we started the clinic is that we would be able to use our 340B savings to really support those that are either underinsured or uninsured. So it has not been an issue for us that has significantly impacted us in a way that we can't be providing those services or turning anybody away.
Awesome. Well, that's really good to hear.
I was going to ask if my house is at capacity, if you are on a waiting list or having to turn anybody away.
No, we haven't turned anybody away. We have received an increase in STI calls that we probably have about 10 to 20 calls a day. So we're really trying to accommodate people, and we haven't had an issue. We have capacity. We have additional providers that are joining the team here soon. So we should be able to, one of the goal is to really fill the gap and the cracks in the system to be able to support folks that are coming in. So, and of course we also have a mobile unit that we're deploying out into the communities. So that is another way for us to support people with PrEP. But thank you for that question. It's a great question. And sorry I missed the call. I had a doctor's appointment, so glad to be here.
Glad you made it. Well, with that, because we are a bit short on time, I wonder if we can move on to Dash and Fast Track Cities update. Thank you for all the wonderful things you've already contributed, but what do you want to share with us about Fast Track Cities?
Well, I talked a little bit about what our policy strategy and interest is for 2023. I would like to get more into the criminalization space on the Hill, simply because there needs to be more voices that are in it, and we need to show a little bit more of ourselves, me meaning me, on the Hill in places that now have fast track cities. We have 31 different cities in the country that are under fast track. A handful of them are not in the EHE jurisdictions yet, are facing greater challenges, sometimes greater challenges, because they are not a priority one jurisdiction, and that's unequitable for me. So I want to be able to show up for all of them. We have set our dates, and we'll be opening up registrations for Adherence 2023. It will be in Puerto Rico. It'll be in Fajardo, which is the eastern side of the island. We are always looking for submissions for abstracts for our workshops. So if anyone is doing any research or abstracts, we're opening it for that. We are going to be doing a proposal to HHS to hold a White House summit to rethink the current national HIV response due to the conversations I've had like today. There are things that are not going very well in many respects and aspects, and due to changes that have happened like 340B. With that in play more recently, that has thrown a lot of continuums out of whack. Not only that, there needs to be a conversation about, let's say for 5 years from now, 60% of the people that are involved in the HIV response nationally, 5 years from now, they're going to be fine. They're going to remain at an undetectable level, and they will not have to worry about being disconnected from care. They will not have to worry about their life being disrupted at all. But there's a 40% of the population in which the current HIV response at the federal level, and all the ways in which money comes down to places, all the ways in which proposals are put out, it doesn't work. And it doesn't work for multiple reasons. And it's very bureaucratic. But there needs to be a concerted talk, 2-day talk with HHS and ONAP at the White House, or at ONAP's offices in the White House, about specific issues related to health financing and responses that are multi-bureaucratic, so that it works better for those populations that are the most in need and the most disconnected, and consist of the good chunk of that 40% of the population that it doesn't work, therefore specific reasons. So that will be occurring sometime in 2023. I'm thinking April. But what we would want to do is reach out to some stakeholders to bring them into DC. I have my thoughts. We can't bring a ton of people, but my thoughts are to bring in specific places in which there's a high HIV burden, but they're not part of EHE. And too often our national response is everything is pushed towards EHE. Everything is pushed towards EHE. And I get it, but you're not in EHE. Minneapolis is not an EHE. Denver is not an EHE. And I don't view that as that's okay. There needs to be a rethink because we all use the same structures when it comes to the federal response. But not all of us have the same access to money. And not all of us have all the same access to the CDC stuff that comes out through EHE. So that's something I think about. I'll do what I can to construct that. I would like to bring someone, at least someone from Tennessee, from Nashville, maybe Memphis is EHE jurisdiction, but that's it. We are going to be holding a series of workshops that are dedicated to aligning EHE plans to the national HIV strategies. What I'd like to do is propose to my funders another series that does not focus on EHE, that focuses on cities that are not in EHE. I think one of my biggest pet peeves about what I do for my work is everything has now been swallowed up by just working with EHE cities because it's such a heavy burden. And I have to keep reminding even people at HHS level that there are other cities that are not in EHE, and they need specific strategies, and they're large cities and they're capitals. But also, I did talk about my talk on wanting more policy work when talking about capitals. I want to have a sit-down conversation with all of you or a select subgroup of you when I am preparing to go to the Hill to stump and let you know who I'm going to speak to, what are the things that you need to be reflected, and that way I go in there with your voices and your needs and not just off of what my needs are. I need to talk to them specifically what does Nashville need for your epidemic when it comes to Representative Green, Representative Ogles, and Representative Rhodes. And then finally, I would like to come back to Nashville at some point because it was really fun. So I'll find a way to have an excuse to go down there. Maybe not to the excuse, maybe I should just be like, I should have a weekend down there.
I think we might need you to come down and lead a data meeting of some kind. That's my
I would like that
idea. That's my wish list item, actually.
I'm remiss to not talk about your data dashboard. So we do have a prototype of the dashboard. I will send it out. It's under a password protection. I'd like to launch it. What I will need is data for whatever data is available that tracks the local 95 metrics. And if you discrepancy and maybe one of the metrics is an agreeable metric that we tried, that's fine. Florida, only one of the metrics is up because the Department of State, Florida only manages one of the metrics. But I would like to see what we can do for data and how that can work. I don't know where the I don't know where the barrier is. It's one of the issues. I don't know. But
Dash, your sound is really weird right now, or maybe that's just my computer. I don't know.
It might be my connection.
It's weird for me too.
I'll just say I would like to work on obtaining that data, and only the base 95, if that's available. And that way we can put that onto the dashboard and be able to promote it. The other things I would like are community messages. I've received Mayor Cooper's headshot and quote. Thank you, Brandon. But I would love to have a few more community messages and headshots talking about the importance of ending Tennessee's urban HIV epidemic. I would take any of those, and those would be put up on the website. And anything that is developed by Tennessee or by Nashville, like the dashboard you were considering earlier, with a centralized hub to do different referrals, if that comes to fruition, then that would be excellent to place under the fast track dashboard as another link, so that there's always a link to resources developed by the groups and by institutions And that way, if they come to the fast track site, they'll go to the same places and vice versa. So always have that up and ready. I'm always happy to gather those and put those on the website as well. So that's where I'm at with the dashboard. And I want to follow up with all of you just with that follow up, just to go through what else is needed for that. But yeah.
All right, any questions for Dash about fast track cities?
Also, always happy to take specific requests on technical assistance needs that Nashville would like either a presentation or more information on. And that can be done throughout. I want to be your advocate. I also want to be your supplier of anything that can provide for capacity building modules, education, other cities that have done things. Like, for example, decriminalization. I'm ready to start getting you connected with people that have successfully done that in a state that has previously been very red. So something like that, super easy for me to be able to do, especially if I know it.
Yeah, we'll definitely let you know, but I think certainly a lot of interest from this group on hearing from North Carolina. So we can touch base after the meeting about that. All right, I think we can move on to our last item of new business, which is the new EHE work group. So during our last meeting, a council member asked how the council can support EHE work groups. And currently the best way to do that is by joining one of the work groups and helping the groups to access resources to carry out their projects. And Morgan has created a doodle poll or multiple doodle polls to schedule January meetings for the new work groups, which are HIV testing, data, social determinants of health and prevention, that sort of came out of the EHE summit in September. So please consider joining a work group and completing the doodle poll for at least one group to help the groups get the group's first 2023 meeting scheduled. And I would also ask everyone to share those polls with people they work with who might be interested in joining a work group, and sort of try to get some fresh perspectives in some of these work groups and get some new projects off the ground. Morgan, anything to add on that?
Yeah, I will be sending you all those polls in a little bit. And also, I forgot to add fast track. Where Claire and I talked about possibly having like a fast track work groups, that Dash we could be more connected to you and like providing like the things that you're asking for and helping like the initiative really, get going in Nashville. So that's another possibility if any of you all are interested in being in that work group. But yeah, I'll be sending those out shortly.
All right, and Morgan, anything else you wanted to address, questions or concerns?
Yeah, we just wanted to open the floor for any questions, concerns, or announcements to wrap up the meeting. I'll be sending out the EHA newsletters going from monthly to kind of quarterly. And so that last one for the year will be coming out soon. So if there's anything that you all would like announced, please send that my way. But are there any things that need to be addressed or put on the agenda for the next meeting? Okay, I'm gonna take that as a no. Okay. So, Claire, yes, do you want to close us out?
Sure. So our next meeting is scheduled for Thursday, February 2nd from 2 to 3:30 p.m. So in the meantime, don't forget to sign up for a new EHE work group, or at the very least, share it with everyone you know. And yeah, we look forward to seeing you all again in February. Everyone have a wonderful holiday season, and hope you get to spend some time relaxing and seeing people that you love. Bye, everyone.
Thanks, Claire. Same to you and everyone.
Happy holidays.
Happy holidays.